think as we move forward in this, with all these changes and reforms to our system, I would say that from our perspective, we're listening closely to the words that Giselle, Dr. Mechanic, gave us around being students of history and attentive to what we know works, what we know doesn't work, as we think about changing our system. And indeed, we are in the midst of some substantial reforms, real opportunities to address what we all know, unfortunately, is the fragmentation and lack of coordination that often characterizes our system of care for individuals with serious mental illnesses and substance use disorders. Our current fee-for-service system is not person-centered, lacks accountability for engaging consumers and achieving long-term outcomes, positive outcomes, and over-incentivizes acute care in hospitals over that continuous outpatient engagement. Traditionally, states have taken one of two approaches to addressing these issues when it comes to managing behavioral health care, to the extent that states actually do manage that care. One is to separate that management into specialized separated arrangements, the so-called carve-out models, which have issues of separating the management of behavioral health and physical health, from separating the financial incentives and misaligning those financial incentives, and for not acknowledging the important overlaps, especially, for example, the high prevalence of physical health conditions among people with SMI and SUD. The other approach tends to be the so-called carve-in models. Simply integrate the care and management of these populations and these illnesses into the mainstream managed care systems. And of course, that also has attendant problems and risks. The relative proportion of these populations in the larger managed care arena is relatively small. The opportunity for disinvestment, for the inappropriate restrictions on care that we are all familiar with. So here in New York City, we've been interested in trying to have a balance between these two approaches and these two imperatives: specialization of management and integration of care. And the model that has emerged and that we'll be moving forward with, the so-called, what we're calling now, I think, very nice moniker, health and recovery plans, HARPs, otherwise known as special needs plans or SNPs, is an attempt to really achieve that balance of specialization and integration. These will be managed care arrangements for individuals with serious mental illnesses and substance use disorders. They will be distinguished by their unique focus on these high-need populations, and will have a variety of characteristics that I'll just briefly enumerate, and which address, I think, some of the issues that Dr. Mechanic pointed out. Stronger accountability for metrics, for outcomes, across a variety of domains. Behavioral health, not just the high-cost, easily measurable things like emergency department visits and hospitalizations, but more attention to treatment outcomes, engagement and continuity of care. Increasing focus on physical health metrics. All the primary care and chronic care measures that we know we need to be tracking and monitoring much more closely in these populations. Then more difficult, how to measure recovery, how to think about social factors when it comes to measuring the performance of the treatment system, housing, criminal justice involvement, employment. We need to rethink and expand how we measure